Is there any other pearls of wisdom that you would like to share with me so that way we can all learn exactly from you?
I think the other topic we're really focused on tomorrow is that sort of plantar plate injury.
Yes. Talk about that.
And I think that's really the key to that too is ultrasound on the diagnostic side. So good history, looking at the ultrasound so you can see the defect. And dirty little secret: I hate plantar plate repairs.
They're not you and everyone else.
Right. They're really not that fun to do and not that rewarding because they don't work.
Right.
So a couple of pearls. One is interoperatively. I was trained, and I hate to admit this, but I've been out almost 30 years. And when I finished school, the McGlamory elevator was really popular. Right. Really popular. Everybody loved McGlamory. They still do. I'm not a fan of the McGlamory elevator because I think when you perform that, if you didn't have a plantar plate defect, you have one now, right? Because you just de-articulated the proximal attachment.
Right.
So I don't use those at all, and I recommend when I give the lecture that they don't. When we're looking at plantar plate options, I've become a big fan of the new Paragon toe tack.
Okay.
So basically the philosophy is you're going to make a plantar approach, base of the phalanx, guide wire through, and then you're drilling a 2.8 hole, and a two-piece implant goes in, and you hold the toe in the corrected position. So you're using the plantar, the long and short flexor tendon complex, to hold that toe in place and take over for what the
plantar plate was supposed to do.
Right.
I see.
And you don't have to do an osteotomy in the mat. You don't have to open up and create a lot of dorsal scarring because we know every time we cut into an MTP dorsally, you end up with a worse injury than you had because of the contracture, because of what happens to the extensor hood. So I think doing this plantar plate substitute with the flexor compression with the toe tack has been my new sort of
That's been your
favorite.
New thing.
Yeah,
the patients have a good outcome?
They do, because you can get some medial lateral correction and hold the toe down. The only pearl that you have to watch is in women with smaller bone structure, if they have a small, very small proximal phalanx, you have to kind of keep in mind that the implant is a 2.8, and a 2.8 and a very small bone may be too much. So we've been playing around in our operating room with using some soft tissue anchors. So basically just take an anchor, drill it into the bottom, and I tie the anchor down with the toe in the corrected position without having to use a very complicated
Wow, that is very interesting. How soon can people resume normal activity or ambulate normally after something like that?
Well, I think that we're going to rebalance that whole joint. So I'm typically a little bit more conservative. I mean, I'll walk my sort of bunion patients right away in a cam boot, and most of my 4-foot osteotomy bunion cases are in a soft shoe at 3.5 to 4 weeks.
Okay.
These particular patients I take a little bit longer, so they'll be in a boot up to 6 weeks, and then I tell them they'll spend 6 weeks in a stiffer shoe. I make them go out and buy, if it's wintertime, like a hiking boot, or in the summertime, I'm a big fan of Hoka, H-O-K-A, their shoes, because they don't. They also make me taller. So we use the Hoka shoe because it has a very stiff 4-foot, and that'll be from week 6 out to week 12.
Wow.
They do take a longer time to heal, but you don't have to do any of that dorsal dissection. So that's really been my success.
Well, that's good, because anytime you're dealing with a joint capsule, it's like scary territory. You know, what is your philosophy of the Weil? Just because I have you here.
I know Dr. Weil, senior and junior, very well. Great friends of mine. I use the Weil as part of my practice for many years, and I like it. It's well done. The downside of the Weil is we are making that extensor hood. We're violating the dorsal part of the capsule, which just automatically leads to contracture. But when indicated, I don't think it's a substitution for doing that plantar repair that we're doing with the anchors and the toe tack. But I do think if you do have an elongated met, or you've had an iatrogenically short first ray and you've got to shorten the second to accommodate.
Option.
Right. So I think when indicated, it works really well, and sort of my go-to for fixation there was 1 or 2 snap-off screws.
Well, wonderful. I like it. You have the minimally invasive ways, you have your open surgery ways, and then you just have to be smart about which type of procedure you're doing for each patient.
Right patient, right procedure.
Right. And I like that you have options.
Right.
And that's amazing. So thank you so much for everything. And again, we are here at the Indigo Hotel in Los Angeles at Prison E-Learning Systems Conference. This has been great. And thank you so much.
Awesome.
Okay.